Welcome. Good morning, dear colleagues. I'm very happy to welcome you to the Novartis Satellite Symposium with the title New Options for LDL Cholesterol Management in Atherosclerotic Cardiovascular Disease. Oops. Here is a disclaimer. And with me today are two very well-known colleagues, Professor Lauf, Chair and Professor of Cardiology at the University of Leipzig, and Professor Spedl from the University Hospital in Vienna. He is a cardiologist and he works in the Division of Cardiology, and they are going to share with us some very interesting topics. Here are my disclosures, and here are the objectives of this session, which are fourfold. First of all, we're going to discuss the importance of achieving the LDL cholesterol goals. Second point we're going to address is what are the latest cardiovascular disease management strategies. Third point to be addressed is how do we apply these new, very interesting methods to fight cardiovascular disease in clinical practice. And we're going to close by discussing the key consideration in adopting these new strategies in everyday life. So the structure of this symposium is as follows. First, we're going to hear presentation from Professor Lauf with the subject, how can we achieve these LDL cholesterol goals? And then we're going to go to Professor Spedl, who is going to present a very interesting case from his practice and how complicated it is to sometimes treat a patient currently with cardiovascular disease. Then we're going to go to a Q&A session. This is the part of a symposium that I always find very interesting. So I urge you to please send your questions during this symposium. You have a link, and also don't forget in the end of the discussion to fill out your evaluation forms. And then it will be a short summary and close with some take-home messages. So without further ado, I'm very happy to introduce Professor Lauf, who is going to discuss, as we said, the new treatment options for decreasing LDL cholesterol and decreasing the cardiovascular disease, hopefully. Professor Lauf.
Dear Ioana, dear colleagues, thank you for the opportunity to participate. This is a really important question. How can we achieve LDL goals? And obviously, the question is important because still, and this is sometimes underestimated, obviously, atherosclerotic cardiovascular disease represents the most important cause of death and also disability, not only for men, but also for women. And we have learned that LDL cholesterol, and we have understood this on a cellular and molecular level, is indeed necessary for the development of an atherosclerotic plaque. So LDL cholesterol is causal, and it's needed for plaque development. Without LDL cholesterol, an atherosclerotic plaque cannot develop. And in fact, we have a model from nature, from our patients with familial hypercholesterolemia, and I'm showing you this one example of a young boy who has a mutation in his LDL receptor in a homozygote form. And this one mutation is sufficient to increase LDL cholesterol, and this boy has an atherosclerotic burden that would be equivalent to a 70-year-old. So LDL alone is sufficient to drive atherosclerosis. And in fact, when we calculate from genetic modeling the effect of a 50% LDL lowering early in life, if we could achieve this without side effects lifelong, we could in fact eradicate a majority, depending on the baseline LDL, up to 80-90% of atherosclerotic disease. So atherosclerosis is a preventable disease. Now we have many randomized trials who have shown the efficacy of LDL lowering of statins and other drugs, and those have been translated by the colleagues who write our guidelines into our LDL goals. And you are familiar with this. For our high-risk patients, for patients with manifest atherosclerotic disease, for example, myocardial infarction, we have an LDL cholesterol goal below 1.4 millimole per liter or 55 milligram per deciliter. And for those with progressive disease in secondary prevention, even lower LDL goals are recommended. And our traditional approach, and this is what is currently in the guidelines, is to use lifestyle to prevent events, statins, ezetimibe, and then the PCSK9 antibodies that are available. However, when we look at how we are doing in Europe, and in fact also across the world, it can be very depressing. Just one example of many studies, and this is something very recently published. It's the Vinci Study, showing us that only in a minority of our high-risk patients, LDL goals are achieved. And I would like to point out that the Vinci Study, the investigators were lipid experts. So most of them were running lipid clinic specialists. So obviously these results are much better than what we see from more general data. So clearly, this is telling us that there is need for additional options for LDL lowering, and we have learned that the LDL receptor is the important pathway. So LDL receptor mediated clearance of ApoB containing lipoproteins is associated with reduction of myocardial infarction and death. And there are two novel options that are now available in the pharmacies in Europe that address the LDL receptor. One is bempedoic acid, and the other one is a new type of PCSK9 inhibitor, the inclisiran. So I would like to briefly introduce these two novel principles. Now, bempedoic acid is a prodrug that inhibits cholesterol synthesis upstream of HMG-CoA reductase and has then similar effects. It is especially effective if there is no statin background therapy, as depicted here by this 23.6% LDL reduction with bempedoic acid monotherapy in patients with statin intolerance. It works very well in combination with ezetimibe. So the bempedoic acid ezetimibe fixed dose combination for me really is the way to use bempedoic acid. And we see a 35% LDL reduction on top of statins and approximately 45% in statin-naive patients. There is an outcome study, very important, performed in patients with statin intolerance. It's called CLEAR Outcome, that is fully recruited, and the results are expected, in fact, to report soon. So the second novel option, inclisiran, represents a new mechanism. And there's something fundamentally new about these RNA drugs, because we have been used to do pharmacology outside the cell, using proteins, for example, that inhibit a receptor, with all the problems of drug-drug interaction, hepatic and renal metabolism that complicate our pharmacological strategies. Now, it would be very elegant, and this is actually the mechanism now, to directly address the messenger RNA that is between our genome and the protein very specifically. And there have been several pharmacological advances. And in fact, it's, from my perspective, something like a small revolution in the way we can perform drug treatment. How this can be achieved. Now, the first goal is obviously to get such an RNA drug into the cell, and here a very clever trick is used, and this is using small nucleotides, 20 base pairs, coupled to a specific sugar called GalNAc that is binding to a hepatocyte-specific receptor, so this makes it specific for the liver, that is then taken up the oligonucleotide into the cell. And then there are two different types of RNA drug. One class is the antisense drug. So one antisense is binding to one RNA, and this enables the RNAs H1 in the liver cell to degrade the RNA. So one-to-one, one therapeutic oligonucleotide binds one cellular RNA. And the second are the small interfering RNAs that form a specific complex, the RISC complex, that serves as a template. And once this is formed, it can degrade a higher number of cellular RNAs. An important clinical consequence that such an approach only needs to apply it, for example, every 6 months. And this has been achieved for PCSK9 inhibition. So inclisiran has this very clever modification of this short oligonucleotide that enables it to survive the bloodstream. Then it's coupled to this sugar GalNAc that leads to the specific uptake into the liver cell, and then it results into a 50% approximately in the studies that we have seen so far, LDL reduction on top of oral therapy, on top of maximally dosed statin and so forth. And the data that we have seen so far from the phase 3 LDL lowering program did not point out any problem in terms of tolerability or safety. Now there is an outcome study, the Orion 4 study, that is also fully recruited and ongoing, that will give us more information with regard to endpoint reduction and also additional reassurance with regard to safety. And from a broader perspective, I would like to point out that with these RNA technologies, we now have the possibility to address targets. And this is especially important in lipid metabolism and clinical lipidology, targets that we have not been able to address by traditional pharmacology, for example, with regard to triglycerides, and importantly, Lp(a), where we do not have a potent drug available at the moment. And just as an example, I would like to show you the pelacarsen data. It's also an RNA drug that is able to decrease Lp(a) by 80 to 90%. And the Horizon trial is actively recruiting to answering the question how this relates to endpoint reduction. So from a broader perspective, we are moving in the lipid arena away from fixed dose statin treatment towards a strategy where we use early combination that is individualized to the need of the patient, with important additional options such as the new drugs, bempedoic acid, and especially, and this is what we are discussing today, the inclisiran. And with this, I would like to thank you very much for your attention.
Thank you very much, Professor Labs, for this excellent talk. I hope we have a lot of questions to discuss with you at the end of the session. And now I'm very pleased to introduce Professor Spedel from the Medical University of Austria, who is going to present a complicated, very interesting patient and how he dealt with him. Professor Spedel.
Hello. Thank you very much for the nice introduction. Hello, dear colleagues. So these are my disclosures. So I will present a rather young patient. So he's 40 years old. He's normal weight. His risk factors are hypertension, and he's still smoking. And he has his first myocardial infarction at a very young age of 35. And already 2 years later, he got occlusion of his stents and the next acute coronary syndrome 3 years ago. So this is his angio from 2018. So we see the right coronary occluded, and we already see a very severe diffused left coronary artery. And we then treated his right coronary artery, and he was scheduled for an FFR of the left coronary artery at this time, but 3 weeks later, but he didn't show up. And this was his discharge therapy in 2018. He had ticagrelor, he had aspirin, he was on a beta blocker ACE inhibitor, and his lipid therapy was atorvastatin 14 milligrams. So unfortunately, the patient didn't show up for his second angio 3 weeks later, but he showed up 3 years later in in February this year at our emergency department because he had chest pain again. And at that time, he was only on aspirin and beta blocker. And when we asked him why he wasn't taking a statin, he said it was taking a statin after his ACS for some weeks, but then he stopped because he had muscle complaints. So for sure, we wrote an EKG. Here we already see signs of ischemia, but no ST elevation. So we waited for his cardiac enzymes. We have a positive troponin of 300 nanograms. So he went straight to the cath lab. And it was not good for the patient that he didn't take his lipid therapy, but it's good for us that we can compare the angio from 2018 and 2021 without lipid therapy. So 2018, and he has a massive progression of disease between 218 and 221. And we think that the circumflex is the culprit lesion, the LAD is occluded, and also the right coronary artery that was reopened in 2018 is now occluded again. So a massive progression of disease in this patient within 3 years without lipid lowering. So we treated his circumflex, couldn't open the right coronary artery in the acute setting. So fortunately, the patient was hemodynamically stable and went up to the cardiology ward. And in the next morning, we got the lipid panel of our patient, and we see an LDL cholesterol of 165 milligram per deciliter, and we measure Lp(a) in all our coronary patients, and we were sure that we see a massive elevated Lp(a) because of the early disease and the massive progression, but it was moderately elevated only with 115 nanomoles per liter. We then put the patient on lipid-lowering therapy, and we started with ezetimibe and rosuvastatin. So all our patients that are treated with PCI get a dual therapy now out of ezetimibe and statin. And because our patient had muscle-related symptoms, we start with the other potent statin. So he had symptoms on atorvastatin. So we start with rosuvastatin, and we start with the medium dose. So we don't want to start with the high dose because we want to decrease the risk of new muscle symptoms, but we also want to avoid to treat a coronary patient only with a low dose statin. And we have our standard operating procedure where we see all patients that are most probably eligible for PCSK9 inhibition again after 4 to 6 weeks. So if patients have an LDL cholesterol above 160 without statin or above 190, we see them again in our outpatient clinic 4 to 6 weeks after the event to see if we should prescribe a PCSK9 inhibitor, where with the threshold for prescription Austria is 70 milligrams per deciliter right now. So same to our patient, we saw him again after 4 weeks, and these are now the lab values under ezetimibe and rosuvastatin. So he had an LDL cholesterol of 106 milligram per deciliter, which is not what we expected. So we started with 165. So our patient, when we asked him, he admitted that he took ezetimibe every day, but he didn't take his rosuvastatin every day. He skipped some doses because he had some muscle pain again. So what's the next step? So for sure, we keep in on ezetimibe. We decrease the dose of rosuvastatin. We try if we can tolerate the 5 milligram dose, and we started our patient on inclisiran 248 milligrams. So, and in inclisiran, we have an injection at day 0, then the second injection after 3 months, and thereafter every 6 months a subcutaneous injection for our patient. So we saw him again after 3 months for his second dose of inclisiran. And fortunately, we reached the LDL goal in our patient Now he has 48 milligram per deciliter. And we also see, like with the PCSK9 antibodies, a moderate decrease of Lp(a) to a little below 100 nanomoles per liter. So not only our patient, but many patients don't reach their LDL goal, and we see that the drug adherence is low. Inclisiran achieves so far an effective and sustained LDL-C reduction with a favorable safety profile. It's injected only twice per year, so this could improve the adherence of patients to lipid-lowering therapy. But I also think that we need organizational improvements to see our patients again use, for example, LDL cholesterol thresholds to guide the plan for the therapy to improve the LDL goal attainment in our patients. And this is a picture of our first patient that we treated worldwide with inclisiran out of a randomized controlled study at the end of January. Thank you very much.
Yeah, thank you very much, Professor Spedel, for the very interesting case presentation. I want to thank both speakers for also sticking to the time, so we can have some time to answer the questions that are already coming through. I'm starting with a question directly, specifically to Professor Laus, and I read, how many cases of homozygous FH do you have in your clinical practice in 1 month?
In Germany, the estimated prevalence is approximately 1 or 2 per 1 million of inhabitants. So it's extremely rare. So we have only very few patients with homozygous FH. However, the prevalence rate for heterozygous FH is approximately 1 to 250. And now we are increasingly detecting, I mean, there's a large number of those patients that are not detected. We know this from the German Care High registry and the FH registry of the EAS. And this, in fact, is a significant number every day we have our clinic.
Excellent. There's a follow-up question that you may also like to respond to. The same colleague asks, do you use the FH Dutch lipid clinic criteria for confirming the diagnosis of FH, or do you prefer genetic testing?
The first step is the clinical detection. So the first indicator is a high LDL cholesterol above 5 millimole per liter or 200 milligrams per deciliter, and a positive family history. The cutaneous signs, such as xanthoma and xanthelasma, we only see in a minority of our patients, and I would like to recommend you to look at the paper by Katzmann et al. In atherosclerosis of this month, where we published these data. So high LDL and positive family history for cardiovascular events detects these patients. I use genetic testing because this increases patient adherence and stringency of treatment, especially with regard for using a drug such as the PCSK9 inhibitors.
Okay, thank you very much. There's another question that maybe Professor Spedel, you can address. Our colleague writes, recently I have seen a very young patient with high cholesterol levels. Do you recommend the screening in this class of patients? In what age we should do to start screening, and how can we do it?
So the guidelines recommend that everybody should see his lipid panel around the age of 40. However, if you have a positive family history of coronary artery disease or any atherosclerotic disease, you have to measure your LDL cholesterol very, very early, and I always suggest latest about 20, because that's the time where we really want to start latest our therapy if a patient has FH. So not to wait too long.
Maybe I'm more aggressive, but I starting at age 8 if a patient needs it, and I think they are also approved, so it's not an off-label use. Another question directed to you, Professor Spedel, is inclisiran already available in Austria? How soon can it be expected in UK and the rest of Europe?
So, inclisiran is available in Austria since the beginning of the year. Unfortunately, I don't know how's the rollout in the rest of Europe.
As far as I know, the company can correct me if I'm wrong, but I think they have applied in the rest of Europe, and they're just accepting Germany. In Germany, it is approved. In Austria, it is approved, and in other countries is under consideration. A question for Professor Loves. When do you prefer bempedoic acid over inclisiran?
So the LDL lowering of a PCSK9 inhibitor, and I've shown you the data for inclisiran with a 50% LDL reduction on top of all oral therapies are greater. However, access to PCSK9 inhibitors is limited in many countries, also in Germany. So oral options are very helpful, and especially the bempedoic acid ezetimibe combination, and especially for patients who have problems tolerating a low dose or any dose of a statin, is therefore a helpful intermediate step. So it depends, as always, on the risk of the patient and how far away we are from reaching the LDL goal.
Thank you very much. And I think I have one last question, a personal question to Professor Spedel. In your patient, what made you start inclisiran and not a PCSK9 antibody?
Yeah, especially this patient who didn't show up for his second angio 3 years ago, who didn't discuss why if he has some other options than a atorvastatin when he had muscle pains. We had the feeling his compliance and adherence is not so good, and we were really happy to have a treatment for him. First, where we see him again after 3 months, and we will see him again after 6 months. And we have a treatment where we can be sure that, especially in this dangerous time after the acute coronary syndrome, we can sustainably lower his LDL. And we were not so sure that he will take his injections every 2 weeks with a PCSK9 antibody.
Okay, so to summarize, you had a fear that the adherence would not be so good, and because the drug is only given twice a year, the chances are much higher. Okay, thank you both very much. Now we have to go to the closing points. I just want to very briefly summarize what did we discuss today. I think we have like 3 take-home messages. One is that the LDL goal attainment rate is extremely low. The drug adherence is also low. The tragedy is that we can reach the LDL cholesterol goals if we only use the plethora of very good LDL cholesterol lowering drugs that we have. We can use combination therapies. We can use this individualized. We can combine various mechanisms of action. So we have the tools to bring patients there, not all, but many. So we should work on going over our inertia and using the possibilities we have. And the last point is that these new therapies of small interfering RNAs that have low frequency of administration may be very helpful in improving drug adherence. I would like to thank at this point the Professor Laus and Professor Spedel for their wonderful presentations. I would like to, of course, thank the sponsor, Novartis, for giving us the opportunity to discuss these issues. Most of all, I would like to thank you, the ones who sent questions and the ones who listened to us. And I want to tell you that this session is also available online in the ESC platform. And last but not least, I want to remind you that in a couple of hours at 3 o'clock, there is a very interesting symposium again, satellite symposium from Novartis, where the chair is Professor Lale Tokosoglu, and the speakers are Professor Packard, Professor Nichols, and Professor Ray. And the very interesting topics they're going to address are, what are the horizons, the new horizons in cardiovascular disease management? What are the risk factors for ASCVD plaque development? And talk a little bit more about the relationship between LDL cholesterol and cardiovascular outcomes in ASCVD. Again, thank you very much for being with us, and I wish you a very nice Sunday and a very nice Congress. Thank you.